Another Sunday coffee here with Dr. Childress. Um, Today, I want to talk about euphemisms for child abuse. That is really problematic, and because it hides the child abuse from view. And I've worked child abuse. Okay, I've been clinical director out working with kids in foster care, and DCS, Department of Children's Services, was our primary referral source. So I've treated all forms of child abuse: physical, sexual, neglect, and psychological abuse. And I've led the treatment teams for all those forms of child abuse. So I'm a trauma psychologist out of foster care and child abuse. And that's what I'm doing in the family courts, because this is child abuse over in the family courts. So today I want to bring with to you some of the fundamental knowledge and the standards of practice out of child abuse world, because that's what we have. We have child abuse, and that's why I'm here, is because it's child abuse. And the first thing that's important to understand about child abuse when we're working with it and that domain of things is to not use euphemisms that hide it, that we have to acknowledge it's child abuse in order to be able to effectively treat it. And if we start hiding it under euphemisms, then we won't be able to properly protect the child and properly intervene on the situation. So that's number one, is we in child abuse world, if you're working with potential child abuse, don't use euphemisms as a professional. Now, we can soften it as we talk to people, but our professional diagnosis, has to be professional. And at some point, we need to address the child abuse with the parents and the child and everybody. We have to deal with reality, not our social sensitivities. So let's start talking about what that's like. So fundamentally here, using euphemisms for child abuse hides the child abuse from view and from proper intervention. Diagnosis guides treatment. If we don't identify it as child abuse, then we don't employ the proper interventions for the child abuse because we haven't identified the child abuse. So that's really, really important. When there's child abuse involved, we have to call it child abuse, because that then leads to the interventions. And child abuse should always be called child abuse. The euphemisms in the family courts that are currently being used to hide the fact that it's child abuse are parental alienation. Alienation, that's been used for like 40 years, and you've seen the outcome of 40 years. There's been no intervention on the child abuse in the family courts because it's been hidden by this term, this made up pathology label of parental alienation, instead of the actual diagnosis, which is child psychological abuse. And so we need to get rid of these euphemisms and start calling it properly, professionally, what it is. We'll talk about that in a second. The second and third ones that are coming on board right now are out of the forensic custody evaluators. They're trying out resist refuse dynamic. It's the same thing as parental alienation. It has no research ground to it. It's just another made up pathology label. Only this time it's not by a psychiatrist. This time it's by the forensic psychologists. But they're still making up things to hide the fact that it's child abuse. It's not parental alienation, it's child abuse. It's not resist refuse dynamic, it's child abuse. And the third one that the forensic psychologists are coming up with is this thing called parent-child contact problems. These are all made up pathology labels that hide the fact that the pathology in the family courts is child abuse. And I want to emphasize this so clearly, because this is fundamental to the treatment of child abuse. We don't call it problematic parenting. We don't say the parent got upset. We say the parent started beating their child, and it's child physical abuse. Okay, that's what we call it. We don't say the parent got upset. We don't say the parent scolded the child. No, the parent, it's child physical abuse or child sexual abuse. The parent didn't become overly affectionate syndrome with the child. No, it's sex abuse. Okay, and we have to call it child abuse so that we can intervene properly on it. So all of these euphemisms that people are using need to be put aside, and the mental health professionals, the doctors need to lift their level, improve their level, their standard of practice to a proper professional ground baseline. Right now, they're practicing beneath professional standards of practice. And so we need to get back up to just baseline levels of professional competence and professional obligations and responsibilities and things. It's really bad over here. So the DSM-5 diagnosis of the pathology in the family courts, and I'm willing to debate this anytime, get a online moderated debate and we'll say, is the pathology, this delusional thought disorder or factitious disorder, is Dr. Childess correct? I'll say yes. You can get somebody who say wrong, and we can talk about this, whether or not this is a diagnosis. But this is the diagnosis. Okay, I'm a licensed clinical psychologist. I have experience with delusional thought disorders, 12 years at UCLA working with schizophrenia. I have experience with factitious disorders. I was trained at children's hospitals. My family systems therapist. I know attachment. I've got early childhood mental health expertise. This is and I'm out of foster care and trauma and child abuse. This is the diagnosis for the pathology in the family courts. Okay, so I'll debate it, but this is it. And the pathology is a shared delusional disorder, persecutory type shared. That's a DSM-5 diagnosis of 297.1 and an ICD-10 diagnosis of F22. It's a factitious disorder imposed on another. It's a false attachment pathology, a factitious attachment pathology imposed on the child for secondary gain to the narcissistic, borderline dark personality parent. The DSM-5 diagnosis is 300.19. The ICD-10 diagnosis is 68.10. It is, and now here is the most important diagnosis. And I want to emphasize this again, because it's those other two diagnoses. In DSM-4, we would call them Axis 1 diagnoses, and the V codes are modifying the Axis 1 diagnoses. That's how diagnosis works. And so the straight numbers are your main DSM diagnosis. So we got a delusional thought disorder. That's a psychotic range disorder. And we've got factitious disorder imposed on another, a false, that's classically Munchausen by proxy, also called medical neglect over in the medical fields. So we've got, and both of those, either one or both, wind up on the child psychological abuse diagnosis. And that's the diagnosis we're going to be acting on, because that's a dangerous pathology. There's three dangerous pathologies: suicide, homicide, and abuse. Child abuse is a dangerous pathology, so that kicks us into a new professional category. When we're in the abuse range, all sorts of things start to happen for us as professionals. So either one or both of those diagnoses are a child psychological abuse diagnosis, a modifying DSM-5 V code of 995.51 and an ICD-10 of T74.32. And there's a second abuse diagnosis involved, a second dangerous pathology, which is spousal or partner abuse psychological DSM-5 B995.82 and ICD-10 Z6911. Now, let me point out something about these diagnoses here, the two abuse diagnoses. The fundamental pathology is spousal abuse of the targeted parent using the child and the child's induced pathology as the weapon of spousal emotional and psychological abuse of the ex-spouse targeted parent. Okay, that's the primary driving force, the motivational force for the narcissistic borderline dark personality parent. Now, in weaponizing the child as a weapon of spousal abuse, the pathological parent creates such significant pathology in the child that it becomes child psychological abuse as well. And so we have two abuse diagnoses, but the lead one for causality is the spousal abuse diagnosis, with the child abuse diagnosis following. The lead diagnosis for treatment, however, is the child abuse diagnosis, with the spousal abuse diagnosis following, because the child has a whole lifetime to come, and our primary concern will be a safety plan for the child abuse with a secondary safety plan, mindfulness to the spousal abuse concern. So we're going to get the spousal abuse concern under wraps because we're going to fix the child's attachment pathology towards that parent. But our focus is going to be on fixing the child's attachment pathology, getting the child a normal range childhood. So those are the DSM-5 diagnoses. That is an accurate diagnosis of the pathology. I will debate this with any mental health professional anytime. Let's get an online, and that's what I'm looking to do at this point, is to get a professional organizations, AFCC is ultimately my goal, to sponsor some of these debates. Is this the diagnosis? Let's get an online moderated debate to see if this is true. Or if not, if no one's going to debate this, if everybody accepts that this is the diagnosis, then we need to be shifting over into treating child abuse. And the whole forensic field needs to shift into treating child abuse if I'm right. And guess what? I'm right. It's child abuse. So all the mental health professionals and family courts are currently failing in their duty to protect because they're failing to diagnose a child abuse. You want to argue with me about it? Let's argue about it. But it is child abuse. And the professionals need to start diagnosing it and start protecting children and protecting their parents from child abuse. And that's just a fact. So why is it important to use the term child abuse? There are three clinical reasons why it's important to use the term child abuse. The first, all three of them have to do with clarity. That's why we use diagnoses and formal professional diagnostic categories. We use them for clarity in communication and understanding, because they have defined, they have clear definitions that are founded in research support. So first, it's the clarity for treatment, because if there's child abuse, we need to have a child protection response, and that means a safety plan. And then we go into a treatment plan. So let me explain something, because I'm from child abuse again. Let me explain something about a dangerous world, which is suicide, homicide, and abuse, child abuse, spousal abuse, and elder abuse. When we are in that category of pathology, dangerous pathology, we don't go to a treatment plan. We start with what's called a safety plan. It's much more active crisis intervention kind of thing. And so for suicide, or if we have active spousal abuse and mom's getting beat, or we have active child abuse, it's a very active intervention right off the top called a safety plan. Then once we make sure everybody's safe, we then move into the treatment plan. So if we acknowledge that the pathology in the family courts is child abuse, then we need to then move into a safety plan with the child, okay, from a treatment perspective, that we need to then inform the court. And what's the safety plan for child abuse? Protect the child. So we protectively separate the child from the abusive parent, this physically abusive parent, the sexually abusive parent, the neglectfully abusive parent, or the psychologically abusive parent. 4 DSM diagnoses, all equally bad in the damage they cause. If we have a diagnosis of a child abuse, we protectively separate the child from the abusive parent 100% of the time. Okay, so that's why it's important, because diagnosis guides treatment. If we have a psychologically abusive, alive parent, then we need to protect the child from that parent. I don't care what the child's superficial looks like. Oh, I love that parent. He's so wonderful. The other parent's so evil. I love. That's all the pathology. Okay, that's the cross-generational coalition. That's a shared delusion. That's a factitious disorder. That's the child abuse that we need to protect the child about, because you got the damaged on the attachment bond with the normal range parent on the other side. And so we need to fix that attachment bond and identify, diagnose the child abuse. And so it's for clarity of treatment. But in addition, though, clinically, it's for clarity for the abusive parent. And that has to do with breaking and delivering diagnoses. Let me talk about that for a second. Now, I'm trained in the delivery of diagnoses, in breaking and delivery diagnoses out of Children's Hospital of Los Angeles and then Children's Hospital of Orange County as a pediatric psychologist. And the reason is those two terms are a little bit different. When a child has cancer, or let's say, cancer. The child has cancer. So when the test results come back and the oncologist, the cancer physician, recognizes that the diagnosis is going to be cancer, they call down to the psych department and ask for a psych consult on the cancer diagnosis. So then we come up, they send up a pediatric psychologist to go up and be in the diagnostic, in the breaking of the diagnosis with the patient. So they call the family in and say, we got our test results back, and the family comes in to meet with the physician. The physician's in the room with the pediatric psychologist. Okay. And the physician says, the test results came back, we got cancer, and this is the type of cancer, and this is what treatment we recommend. And the physician answers all the questions about treatment, what's going to happen. Oh, my kid's going to be okay, and everything. And that's called breaking the diagnosis. So the physician is there to break the diagnosis. The reason I'm there as a pediatric psychologist, I keep my mouth shut during all that, because that's medical stuff, is the physicians are going to answer the questions and the physician's going to leave the room. Okay, that's my job then. My job is delivering the diagnosis, which means they're going to start crying and they're going to be so upset. They're going to be worried about that. My child going to be able to survive, and what's this going to be like for my child? And oh my goodness. And that's where the pediatric psychologist helps them process what that means, what the diagnosis means. And I'll be meeting with them several times over the course of time, and the child and stuff, to help everybody process the diagnosis of cancer. So that's delivering the diagnosis. The first part is breaking the diagnosis. Now, with child abuse, we need both halves of that. So the mental health professional, when we get a diagnosis, typically that's Child Protective Services when I was working, so they move the child into foster care. So they break the diagnosis. We're taking your child and putting them in foster care because you're physically abusive or alcoholic and neglectfully abusive or something. So they break the diagnosis. But then the mental health person at my clinic, the kid would be sent to my clinic and the parent would come in and say, I didn't beat the child. It was just like, no, they don't understand. And, I'm not abusing my child. And it's up to the psychologists at the clinic and treating the child and the things and the family to deliver the diagnosis. No, what you were doing was, we view it as child abuse. And we'll make that statement. Now, the parent's going to push back. Now, that's okay, because we're accusing them of child abuse. We're saying they're an abuse, and they don't want it. That's a parent. They don't want to abuse their child, but they can't help themselves. I'm talking physical abuse or neglectful abuse or psychological abuse. Sexual abuse, I'll put in a different category. But for the generally abusive parents, and that's where it's really important for them to understand the severity of their problem, to develop some sort of self-reflective insight into, your parenting crossed a boundary. And once they accept that self-reflective insight, then we can help them make the changes necessary so they're not abusive, and we can get the child back bonded to that parent, because we always want them. That's going to be mom or dad for the rest of the kid's life. We always want the child receiving as much love as possible, but not from a dangerous parent. So we have to make the parent not dangerous. And the first step to making them not dangerous is to get them to acknowledge that they are dangerous. So that's the clarity that we need on this. And with psychological abuse, it's kind of fuzzy. So that's where it's really important to be able to go into that allied parent and say, I understand that you think you're a wonderful parent, but from a professional standpoint, we view it as child psychological abuse, and here is why. And here's what you can do about it. Okay, so all of that becomes treatment-oriented focus to fix the abusive parent, to protect the child. So that's the second reason why it's important to use the term child abuse when there's child abuse. The third reason is for clarity for the child, in orienting the child to reality with appropriate professional framing. So we have a shared delusional disorder. The child's reality is all messed up. It's flipped around and they're manipulated by this parent, and a factitious attachment pathology being involved. So the child's grounding in reality has been severely disrupted by the pathogenic parenting, pathology creating parenting of a narcissistic borderline dark personality parent. It collapsing around the divorce. I've twisted up the child. It was reality, sense of reality. And so what we need to do is go back and reorient the child to reality, but do it in a way that's developmentally appropriate to the child and that allows the child to maintain healthy attachment bonds to both parents. So we can't resolve the alienation with one parent by creating it in the other, so we can't resolve the child abuse in one parent by creating the breach and the child abuse from the other parent. So we need to bond into both parents. Okay. And so we need to present a professional framing of the child abuse in a way that the child understands that the reality coming from the allied parent is not reality, and that the professionals around the child have viewed it as sufficiently problematic that we are determining it is child abuse. Use the term with the child. We are determining it is child psychological abuse, the severity of what's going on with your allied parent, because they're creating such severe problems with the other parent. And so we believe it's child abuse. And we need to protect you from that parenting. The moment we make that statement, we're good. Okay, we've oriented the child. Child will say, no, I love that parent. And that's everything. And the other targeted parent is awful. And we say, okay, I got it. We back off of the child abuse diagnosis at that point. We don't need the child to accept it. We need the parent to accept it, not the child. We back off of that diagnosis. We've communicated our understanding. We then move solution focused to, okay, what are we going to do about this though? Okay, our concern is your emotions and behavior and you're with a targeted parent, normal range targeted parent. So if we get those into line, then we restore everything 50-50 and goes back to normal and everything's good. So the symptoms that we're concerned about, young person, is your relationship. So let's fix that. Get that back. We just want you to be loved. Just that parent loves you. So just accept their love. That's all we're asking for. Normal range, parent-child relationship rating scale. So just normal range and then everything is well. So we go solution focused. But it is important that we start with reorienting the child to reality, that we are called the eyes of the other. And so the eyes of the other are going to come in and stabilize the child out of the triangulation. No, this is reality, and this is where we're moving into a child protection response, and that's our judgment. And it's right, it's accurate, because when child abuse is a considered diagnosis, our diagnosis has to be accurate 100% of the time. I would recommend that one of the ways to achieve that is to get a lot more second opinion consultation and consultation groups in the family courts. That will improve diagnostic accuracy a lot. So that's your three clinical reasons for saying child abuse and making the diagnosis of child abuse explicitly. So, the pathology in the family courts is the collapse of a narcissistic, borderline dark personality parent into persecutory delusions, who is then creating a false, factitious, artificially created attachment pathology in the child for secondary gain to the parent of manipulating the court's decisions regarding child custody and to meet the parent's own emotional and psychological needs. Okay, so I gave you the DSM-5 diagnosis. Now I'm giving you the clinical description diagnosis. So I'm handing it to you, the professionals, on a silver platter. Here's the clinical description. Here's the DSM diagnosis for this. And the DSM diagnosis is child abuse, right, and spousal abuse. So attachment pathology and child abuse. Attachment system is a motivational system. Motivational systems always have direction. The only cause of severe attachment pathology, a child rejecting a parent, a flip in the motivational direction of the attachment system, is abusive range parenting by one parent or the other. Either the targeted parent is abusing the child in some way, thereby creating the child's attachment pathology toward that parent, a two-person attribution of causality, or the allied parent is psychologically abusing the child by creating a shared induced persecutory delusion and false factitious attachment pathology in the child for secondary gain to the parent, a three-person triangle attribution of causality. So there's our differential diagnoses. Now, it becomes really important to accurately diagnose this particular pathology 100% of the time. A shared persecutory delusion is a particularly dangerous professional pathology, because if you believe a shared delusion, you become part of the shared delusion. You become part of the pathology. And when the pathology is child psychological abuse by an allied narcissistic borderline dark personality parent, you, the mental health professional, become part of the child abuse because you believe a shared delusion. And when that pathology is also the spousal psychological abuse of the targeted parent by the allied parent using the child as a weapon, you, the mental health professional, become part of the spousal abuse because of your misdiagnosis. And so it becomes really, if you misdiagnose ADHD, you don't become a child abuser. If you misdiagnose autism, you don't become a child abuser. If you misdiagnose a shared persecutory delusion, you're going to participate in the child abuse. So that's why it's really, really important for the mental health professionals to be competent in the diagnostic assessment of delusional thought disorders. Are they? No. So we have massive amounts of misdiagnosis of child abuse, not misdiagnosis of parental alienation, not misdiagnosis of resist-refuse dynamic, not misdiagnosis of parent-child contact problems, misdiagnosis of child abuse that leads the professionals to participate in the child abuse. Not participate in the alienation, participate in the child abuse. Okay. It's important to understand. Because professionals have two legally obligating duties. They're called the duty of care and the duty to protect. Here's from Wikipedia. Now, all mental health professionals, you guys should know this. I'm quoting from Wikipedia. Holy cow, to you mental health people. You have, your first is duty of care. In tort law, a duty of care is a legal obligation that is imposed on an individual requiring adherence to a standard of reasonable care to avoid careless acts that could foreseeably harm others and lead to claim in negligence. Okay, so your key words: reasonable care, foreseeable harm, and negligence. From Wikipedia, duty of care is often patient abandonment. If you can't pay your fees, we can't just dump you out. We have to give you some referrals to low-cost services or something like that. That's typical duty of care, but it expands more. We have obligations for that reasonable care side of that term. Competence is one of them. 2.01 of the APA Ethics Code. Then the second duty is duty to protect. And in medical law and medical ethics, the duty to protect is the responsibility of mental health professionals to protect patients and others from foreseeable harm. So again, you see both of those foreseeable harm things on both duty of care and duty to neglect. Well, when the only cause of severe attachment pathology is child abuse by one parent or the other, then there's a foreseeable harm to the child, one direction or the other, that would activate both duty of care and duty to protect obligations. So duty to protect obligations are active for all mental health professionals in the family courts. And since the only cause of a directional shift in the attachment system from always wanting to bond to a parent, because the other motivational direction is death by predation and starvation. So the attachment system always motivates the child to bond to the parent, because motivational systems always have direction, unlike regulatory systems that can go up and down a motivational. And so to flip the direction of a motivational system to want to sever a parent-child bond requires child abuse, either by the targeted parent, creating the child's desire to flee that parent, or by the allied parent who's creating a false or factitious attachment pathology in the child by creating a persecutory delusion in the child that destroys the child's attachment bond to the other parent. So one way or the other, it's going to be child abuse. That means, follow the logic here, that means if the only cause is child abuse, that means all the mental health professionals should be returning a child abuse diagnosis one way or the other, because that's the only cause of the symptoms of the pathology. So the question becomes, for the forensic custody evaluators, which parent is abusing the child? They don't say. They don't diagnose the child abuse. They hide it. They hide it sometimes under euphemisms like parental alienation or resist-refuse dynamic or parent-child contact problems. Those are the euphemisms that I read in their reports. Do they use the term child abuse? No. Do they assess for child abuse? No. And so they are failing in their duty to protect obligations. They are failing to show proper care with the pathology. Let's talk about negligence. That's Google negligence, failure to take proper care in doing something. And from the Cornell Law School definition of negligence, negligence is the failure to behave with the level of care that a reasonable person. Okay. So I will propose to you that as a clinical psychologist, Dr. Childess represents the standard for what a reasonable psychologist would do with knowledge of attachment and child abuse and the application of the DSM-5 and factitious disorders. So I got the DSM-5 and I've got knowledge of trauma and attachment and child abuse and attachment, which is competence standards, ethical standards for competence. That would, my diagnosis is what child psychological abuse is what a reasonable psychologist would find in that situation. And so negligence is a failure to behave with the level of care that a reasonable person would have exercised under the same circumstances. Did they conduct a proper risk assessment for the child abuse to the differential diagnosis for each parent? Either the person's actions or omissions of actions, failure to protect, can be found negligent. The omission of actions is considered negligent only when the person has a duty, such as the duty to protect, or a duty to help someone because of their own previous conduct. So, from where I sit as a clinical psychologist, the diagnosis is child abuse, and the mental health professionals, the forensic psychologists, the reunification therapists, the individual therapists, all the involved mental health professionals are failing in their duty to protect because they are misdiagnosing the pathology. If you misdiagnose the pathology, you become part of the pathology. So they become part of the child abuse because they're practicing beyond the boundaries of their competence in the diagnostic assessment of delusional thought disorders, which is what the pathology is. And so, if you go into eating disorders and you don't know anything about eating disorders, kids with anorexia are going to be dying because you don't know anything about eating disorders. And if you go into child abuse and you don't know anything about child abuse or attachment pathology, and kids are going to start dying from, or psychologically dying from, the child abuse because you don't know what you're doing regarding delusional thought disorders and factitious attachment pathologies. So, from where I sit, it's negligence. From where I sit, it's failed in duty to protect obligations. What I have been urging every professional to do in the family courts is to stop using euphemisms for child abuse that hide the fact that it's child abuse. They hide it from the court, they hide it from the child, they hide it from the parents. And meanwhile, the targeted parents trying to get reality out there and say that my child has a false, factitious attachment pathology. If this is false. And no one's believing them because the mental health people are incompetent in diagnosing factitious disorders and delusional thought disorders. And so, and then if you misdiagnose the shared delusion, you become part of the child abuse. So there's a lot of mental health professionals in the family courts who are child abusers and spousal abusers using the child as a weapon. And then you don't even know who are they? All of them, actually, most of them. A few of them are diagnosing the problem, but not the child abuse. And so they're still, even though they identify that there's parental alienation here, they're not identifying that diagnosing the child abuse. And so they're not recommending the protective separation that we would do for child abuse. And so they're failing in their duty to protect obligations, failing to protect the parent from spousal abuse, failing to protect the child from psychological abuse, and become participants in the child abuse because of their failure in duty to protect obligations. So with that, I'm going to close off my talk today on euphemisms. Please, mental health professionals, stop using euphemisms that hide the pathology in the family courts. Let me say one more thing about hiding the pathology of child abuse. In my estimation, as a clinical psychologist, I view the origins of this particular family court pathology as the transgenerational transmission of sex abuse trauma. So it's not the actual sex abuse. The sex abuse happened a generation or two earlier, and this is a ripple of that sex abuse through the distorted parenting that unresolved trauma creates. And so it creates a certain type of unresolved trauma, the type of distorted parenting that then leads to what we see in the family courts around divorce. And one of the things about sex abuse trauma is it's a hidden pathology. That's so characteristic of sex abuse. It hides. And so with sex abuse, we have to use the term. It is abuse. It's child abuse. We can't cover it up. We can't mask it with these euphemisms. So please, all mental health professions, and I recommend all parents, when you use the word parental alienation and you go into your mental health person that says, I'm worried about parental alienation, you know what happens off of that? Then ultimately, let's say you get me their report because you want me to review it. So as I'm going through line by line on their report, and they say, the targeted parent, the mother said, she's worried about parental alienation. I then have to translate for you. I have to say there's no such thing as parental alienation. It's a false pathology. What she means from a professional level is a shared delusion of factitious disorders that then activates the child professional's duty to protect obligations that they didn't do a proper assessment. So I have to translate from your euphemism for child abuse over to child abuse. It's much, much easier on my side and cleaner on their side if you go in and say, I'm worried about child psychological abuse. I'm worried this is a false attachment pathology. I'm worried that this is a persecutory thought disorder or persecutory belief system. Persecutory, use persecutory and use false attachment. False. There, now I read that and say, holy cow, you have told the mental health professional that it's child abuse. You're worried about psychological child abuse. You've used the word. So now their duty to protect obligations are clearly active if there's an allegation of child abuse. You've told them it's a persecutory thought disorder. So now they're clearly in the domain of having to know how to assess for persecutory thought disorders. And you've told them it's a false attachment pathology, a factitious disorder. So now when I review their report, they better do an assessment for the three things that you asked them to assess for. And if they didn't, that's a failure in duty to protect. That's negligence. Okay, so just make it easier for me. Everybody, stop using the term parental alienation because it doesn't exist. You know what does exist? Child abuse. So let's call it child abuse. And if somebody says it's not child abuse, say, yeah, it is a persecutory delusion, factitious disorder on the, it's a child abuse. What are you talking about? And if they don't agree, put me on a debate. Let me get up there. So with that, I'm going to head out to my Sunday. Good luck, everybody out there. I'm apologize for the low level of mental health services in the family courts, and we'll see about getting proper stuff out there and to the kids out there. Hang in there. We're coming. We'll be there soon. All right. So take care, everybody.